Hello, everyone. Welcome back. So let's start with a question. A 62-year-old man with a history of chronic hypertension and hyperlipidemia undergoes autopsy after sudden cardiac death. His aortic valve shows firm rock-like nodules composed of calcium deposits. So that sounds this patient has possible aortic stenosis with aortic calcification. The serum calcium and phosphate levels were within normal limits prior to his death. Which of the following mechanisms best explains these findings? So based on the information we have here, this patient likely have dystrophic calcification of his aortic valve. So the best answer there will be B, calcium deposition in injured tissue due to membrane phospholipid breakdown. So let's see why. So in today's lecture, we're going to be talking about pathologic calcification. And in the previous lecture, we talked about what are the outcomes of necrosis. And then one of the outcomes of necrosis is dystrophic calcification, whereby calcium deposits in necrotic tissue. And what's pathologic calcification? So pathologic calcification is when there is deposition of calcium salts in tissue other than bone and teeth. And what's unique about bone and teeth, that's where most of the calcium are deposited in our body. So what are the two major types of pathologic calcification? So we have dystrophic calcification and metastatic calcification. So we're going to start with dystrophic calcification. So dystrophic calcification, this is when calcium deposits in a dead, degenerated tissue or necrotic tissue. And in patients with dystrophic calcification, their serum calcium and phosphate level are within normal limits. So the reason why the calcium is depositing in those tissue is because those tissue are necrotic, injured, dead, or degenerated, as we saw in the question we did earlier. So let's look at the pathogenesis of dystrophic calcification. So we have a necrotic or a degenerated tissues, and this tissue release phosphate from the membrane phospholipid via phosphatase. So that phosphatase release phosphate from the cell membrane of those degenerating or necrotic cell. And now that gives opportunity for calcium to enter those tissue and bind to phosphate and then form calcium phosphate crystals. And then when you apply your H and E stain, right, so they're going to appear basophilic, they're going to appear slightly blue, as you can see in this image that was taken from a patient with invasive ductal carcinoma. So now let's look at some high yield examples of dystrophic calcification. So one is calcified granuloma, as we see in tuberculosis. And if you have not watched the video that we did on granulomatous inflammation, because we did an extensive job in going through granulomatous inflammation, we talk about different type of granulomatous inflammation. I strongly encourage that you should watch that video, and it's going to help you. The next example there is calcified thrombus. So if you have a blood clot that is chronic, then calcium could deposit in those blood clots. Next is atheroma calcification. So if you have, in the case of atherosclerosis, and there is atheroma formation, with time, calcium could deposit in those atheroma. Next is Mockenberg medial sclerosis, which is calcification of the tunica media of muscular arteries. And it's important to know this is involving the tunica media, and this does not affect blood flow. except if there is now involvement of the intima, like in the case of atheroma or atherosclerosis. And these are the patients on examination. They usually describe them as lead pipe appearance. So when you touch the blood vessel, they appear as a pipe, right? And next is breast microcalcification. So this is seen in conditions like ductal carcinoma in situ, also fat necrosis. And then we did a recent lecture on fat necrosis. So I strongly encourage you guys to watch that video. It's going to help you. Next is pancreatic calcification in the setting of chronic pancreatitis. So if you see an image showing calcification of the pancreas, always think of chronic pancreatitis. Next is ventricular calcification in the setting of infection like congenital infection like toxoplasmosis and CMV. Next example there is calcified stromas in tumor, like in the case of somebody who have uterine fibroid and now the uterine fibroid has calcified. Also breast tumors. Calcified pineal gland is also another one which is age-related finding, and it's an important landmark because it's in the midline when we're reading the CAT scan of the brain. And the last one there is aortic stenosis. So a degenerating aortic valve, calcium could deposit in it. And that's what we saw in the question that we did earlier. So now there's another main example of dystrophic calcification, which is well tested on the exam. And this is called Psammoma bodies. So we call it Psammoma bodies. So these are concentrically laminated calcified areas, which I call them concentric areas of calcification, as you can see them. So we can see multiple on this image. And these concentric areas of calcification, which is what we call Psammoma body, are seen in certain malignancy, certain cancers. And what are the examples of this malignancy? So one is papillary thyroid carcinoma. The second is meningioma. Next is serous ovarian carcinoma, mesothelioma, and prolactinoma. So these are examples where we can find Psammoma bodies. Moving on to the next type of calcification, which is metastatic calcification. So this is when calcium deposits in normal tissue. Normal tissue. Remember, as opposed to dystrophic calcification, whereby calcium deposits in necrotic, degenerated tissue. But here, calcium is depositing in a normal tissue. So the question is that why is calcium interested in deposition in this normal tissue? It's because either the patient has very high calcium and the calcium is looking for where to go to, and now the depositing in the normal tissue, or the patient has hyperphosphatemia, because with high phosphate, that could drive calcium into normal tissue. So let's look at the pathogenesis. So elevated calcium and phosphate leads to deposition in tissue with high alkaline pH or rapid pH changes. And this calcium binds to the inorganic phosphates, leading to calcification and a tissue destruction. And once calcium binds into that normal tissue, then that normal tissue become dysfunction. So that prevents the tissue from doing its job. So let's look at a couple of examples. So common site of metastatic calcification, so it could happen in the basal membranes of the renal tubules, as we're going to see in a second, alveolar wall in the lungs, internal elastic lamina of the arteries, acid secreting tissues like gastric mucosa, kidney, cornea, and joints. So let's look at very high yield example for the exam, guys. So one is pulmonary metastatic calcification. So this is seen classically in patients with chronic kidney disease, because as we know, in patients with chronic kidney disease, they have problem, there's deficiency of vitamin D. So there's hypovitaminosis D, right? One. And then number two, the PTH cannot work on the kidney anymore, right? Remember, where does PTH work? Very good. It works at the proximal carotid tubule and at the DCT, right? And then one of the functions of the PTH at the proximal carotid tubule, it activates 1-alpha hydroxylase. Very good. And that 1-alpha hydroxylase, right, is going to help with the activation or hydroxylation of the vitamin D so that we can have our 125 dihydroxy vitamin D, right? Another function of PTH on the kidney, particularly at the proximal convoluted tubule, it helps to increase excretion of phosphate, right? So if the PTH is not working, then you can't get rid of your phosphates, and that will lead to hyperphosphatemia. So that's why patients who have CKD, chronic kidney disease, they have what? Hyperphosphatemia. And that hyperphosphatemia is going to drive calcium into normal tissue, thereby leading to metastatic calcification. And the next example there is nephrocalcinosis, whereby there is calcification of the renal tubular basement membrane. And if this is happening in the collecting tubules of the kidney, so that means that could prevent ADH, antidiuretic hormone, from working, from binding, or from working on those collecting tubule, and that could lead to nephrogenic diabetes insipidus, whereby the patient will not be able to reabsorb those free water back into the blood, and they're going to be they're going to be losing a lot of free water as a result of that. And this is classically seen in patients who have too much of calcium. For instance, like patients who have sarcoidosis, patients who have primary hyperparathyroidism, anything that could cause hypercalcemia, that could lead to nephrocalcinosis, and this could progress to renal failure, guys. So we've come to the end of today's lecture, so let's do some questions. So the first question there is: a newborn is diagnosed with congenital toxoplasmosis. A head CT scan shows multiple periventricular calcifications. Serum calcium and phosphate level are normal. Which type of calcification is occurring? So here we have what? We have a infected tissue with toxoplasmosis, right, which is a form of what? A degenerating tissue or a necrotic tissue, right? And as a result of that, that give opportunity for calcium to deposit in those tissues. So this is going to be a form of dystrophic calcification. Moving on to the next one. A patient with end-stage renal disease on dialysis. And what do we mention about end-stage renal disease? It can lead to hyperphosphatemia, right? So those patients who have increased phosphates develop increasing shortness of breath. Chest X-ray shows diffuse calcium deposits in the alveolar walls. Lab studies show elevated phosphates and a decreased calcium. What is the most likely mechanism? So this is going to be a form of, so a patient who has end-stage renal disease, elevated phosphates, and decreased calcium level. Can somebody remind us what's going to be the parathyroid hormone level? Very good. So there's going to be increase in parathyroid hormone level. So this is going to be a form of secondary hyperparathyroidism. Very good. Make sure you remember. You're going to come back and thank me. So which of the following is the most likely mechanism in this patient? So this is going to be a form of what? Metastatic calcification. So the best answer there will be C. So hyperphosphatemia causing calcium phosphate deposition in normal tissue. So next question. 44-year-old woman is found to have a thyroid mass. Histology of the mass shows concentrically laminated round calcification, right, known as Psammoma bodies, right? Which of the following tumors is the most likely present? So this is going to be a case of what? Papillary thyroid carcinoma. And remember, papillary thyroid carcinoma, one of the main risk factors when you are reading the question is going to be exposure to radiation. So somebody who have prior exposure to radiation now develop thyroid mass and the experience of Psammoma body or orphan tiny nuclei. Think of papillary thyroid carcinoma. And the last question for today, guys. A 50-year-old man with long-standing type 2 diabetes presents with polyuria, polydipsia. Imaging shows calcification of the renal collecting tubules or ducts. Labs showed elevated calcium level and a low phosphate. So elevated calcium level, low phosphate. So this could be somebody who have what? Very good. Primary hyperparathyroidism. And what are the causes of primary hyperparathyroidism? Very good. It could be adenoma, particularly if just one gland is involved. It could be hyperplasia if all the 04 glands are involved. Or it could be carcinoma. Very good. What is the most likely cause of this? So this patient, because of the hypercalcemia, likely have nephrocalcinosis, thereby leading to nephrogenic diabetes insipidus. Thank you guys for tuning in today. Don't forget to like, subscribe, share with your friends so that you can keep motivating us to make more videos. And I will see you guys in the next lecture.